The eye has its own share of malignancies, has the rest of the body. Some of the very important tumors related to the eye that need mention are retinoblastoma, choroidal melanoma, and rhabdomyosarcoma, out of which two are predominantly intraocular tumors. The third one is associated with the eye and the periorbital structures. It is the most important thing or the most important question that comes to our mind when we think about retinoblastoma is, how does retinoblastoma actually present? It is known that it is a very malignant tumor, can lead to devastating complications and may be life-threatening if it spreads beyond control. So how do you identify retinoblastoma in its early stages? For that, we should know what the differential diagnosis of leukocoria or a white pupillary reflex in a child is. The following conditions can cause leukocoria in a child, the most important being congenital cataract, retinoblastoma, retinopathy of prematurity, persistent hyperplastic primary vitreous or persistent hyaloid system, toxocara granulomas, Coats disease or exudative retinal detachment due to telangiectatic retinopathy, and retinal detachment itself. Coming to retinoblastoma, it is very, very important for us to know this because with the advent of modern day therapy, almost 90% of eyes and individuals can be salvaged in this disease if timely action and appropriate intervention is undertaken. Most common intraocular malignancy in children, affecting 1 in 15 to 18,000 live births. 25% to 35% of those are bilateral in incidence, and average age of diagnosis is 18 months or 1.5 years. 1809, Wardrop suggested enucleation as the primary mode of treatment of retinoblastoma. Things have come a long way since then. Term retinoblastoma was officially accepted as a nomenclature in 1926. The most important part about retinoblastoma as compared to other tumors is its genetics. One of the most extensively studied chromosomes in the history of genetics, the chromosome 13, is responsible in its abnormal form for incidence of retinoblastoma. Having said that, 94% of the cases of retinoblastoma are still sporadic. Bilateral cases involve a germinal mutation, however, in most of the cases. 15% of unilateral sporadic retinoblastomas are caused by germinal mutations. There is no formula or mathematics to remember this. These are statistics and hence they are important. For this particular condition, they need to be remembered. Mutation of chromosome 13 or the RPE1 gene is responsible for initiation of the cascade that leads to retinoblastoma. Knudsen in 1971 initiated a two-hit hypothesis, which is considered the basis of explaining the inheritance of the disease. For the tumor to develop, two mutations are needed or two hits are needed. In inherited variant, initial hit being a germinal mutation that is present in all the cells. By virtue of the germinal mutations, the other ordinary cells are also predisposed to this particular abnormal genetic composition, and they are predisposed to having other non-ocular malignancies also. In unilateral sporadic cases, however, both the hits are somatic mutations. Genetic counseling and likelihood of disease, nothing but statistics. Still we have to read it. Positive family history, 40% of the siblings and 40% of offsprings of patients can develop disease. In case of unilateral disease with no family history, 1% in siblings and 8% in the offspring. And in bilateral disease with no family history, 6% siblings and 40% offsprings are at risk of developing retinoblastoma. Histopathology of retinoblastoma, the basic thing that gives the retinoblastoma its name. The important point in this to be noted is on histopathology, whether the tumor is a well-differentiated tumor or a poorly differentiated tumor. The classical pathological description of rosettes and florets indicate a well-differentiated tumor. The processes of the photoreceptors, abortive or otherwise, which are seen in the form of florets, and the photoreceptor differentiation or the initiation of the same is seen in terms of the Flexner wintersteiner rosettes. Now this is highly specific for retinoblastoma, whereas the Homer-Wright rosettes are seen in other conditions also like medulloblastoma, and they are rather non-specific for retinoblastoma. So Flexner wintersteiner rosettes and florets by and large are the histopathology which are important for retinoblastoma. In case of poorly differentiated tumor, like all the other cases, you have basophilic cytoplasm, mitotic figures, and you do not have the classical presence of these rosettes. Malignant cells surrounding the blood vessel form something called as pseudo-rosettes, which is not a sign of These need to be differentiated from the classical rosettes of Flexner wintersteiner. Clinical manifestations of the disease, as we already discussed, one of the most important causes of leukocoria. The leukocoria is the first and the most important presentation, rather the most frequent presentation, I would say, of retinoblastoma in 56% of the cases. Second, closely followed by strabismus or squinting of the eye that is affected in 20% of the cases, followed by a red eye, poor vision, after which a group of patients are asymptomatic and a group of patients who have orbital cellulitis secondary to extraocular spread. Three patterns are usually defined for the tumor as seen here. Endophytic erodes into the vitreous cavity and breaking through the internal limiting membrane of the retina and grows as a fungating mass into the vitreous cavity. The second tumor is the exophytic one, where the internal limiting membrane remains intact. Tumor goes outwards into the choroid and the subscleral space and causes a retinal detachment or elevation. Diffusely infiltrating type, in which there is a placoid growth where the retinoblastoma will spread into the layers laterally. This is a very deceptive type of a tumor, and since it does not produce as a space occupying lesion, it is difficult to diagnose and sometimes diagnosed lately. All in all, the spread of the tumor, the most important pathway is the optic nerve. This in itself is very, very important fact while considering the treatment or the treatment modality for the disease. Associated malignancies are especially important in case of presence of germinal mutation, the most notable being osteosarcoma. Pinealoblastoma may be associated with bilateral retinoblastomas and is so called as trilateral retinoblastoma. Metastasis in this disease occur to the brain, the skull, the bones and the lymph nodes in addition to local spread to the orbit. But the primary place from which the tumor exits the eye is the optic nerve. The spread occurs maybe 1 year from the diagnosis. If there is no metastasis within 5 years of diagnosis, the patient is considered as cured. Risk factors for systemic disease. The risk factors actually depend upon how much the tumor has spread or infiltrated into the eye. High risk factors are the spread of the tumor into the anterior chamber, seeding of the anterior chamber, presence of hypopyon, involvement of the retrolaminar portion of the optic nerve behind the lamina cribrosa, and the presence of the tumor in the cut transection of the optic nerve. When enucleation is done for retinoblastoma, especially when it is intraocular, any tumor cells that are found in the stump are an indicator of bad prognosis for the survival. The occasional tumor breaking out through the sclera or extrascleral extension also indicate a high risk for tumor spread and poor quality of life. Diagnosis of the disease. Once the patient is diagnosed with a leukocoria or the patient presents to us for a squint, dilated fundus examination with 360 degrees scleral indentation gives us the true extent of the tumor. If possible, the tumor can be documented with the help of a device called as a REDCam, which gives a wide angle imaging of the fundus. Ultrasonography B scan is a very, very important tool and the most non-invasive tool for diagnosis of retinoblastoma. Highly echogenic foci of calcification from the tumor are diagnostic and suggest retinoblastoma. CT scan with low radiation protocols is very important because in such cases, if they have a germinal mutation, X-rays can lead to further mutations and lead to carcinomas at extraocular sites. MRI for intracranial extension or optic nerve involvement is important. However, MRI doesn't pick up calcification, in that way inferior to the CT scan. Aqueous humor LDH levels are done in odd cases where the eye presents with a hypopyon, non-responsive to treatment with steroids. Classification of the disease. Historically, the Reese Ellsworth classification has been coined and which was moved to prognosticate patients with methods treated with methods other than enucleation, predominantly the external beam radiotherapy. However, the latest classification of intraocular retinoblastoma is the ICOIR or International Classification of Intraocular Retinoblastoma and an international staging system. These are done in relation with a standard photograph that is provided and the tumor is graded and staged according to these classifications. By and large, small tumors less than 3 millimeters outside the macula, big tumors greater than 3 millimeters within the macula, any tumor with subretinal fluid, localized seeding confined intraocularly have the best prognosis for a vision as well as a globe sparing procedure. Management of retinoblastoma is no longer as simple as it used to be. With the advent of more and more vision sparing and globe sparing techniques, the treatment is highly individualized. Age, laterality, location, staging, visual prognosis, systemic condition, and geo-economic consideration are important and incorporated in decision making. Modalities of treatment available are focal treatment with cryotherapy, laser, transpupillary thermotherapy, and plaque brachytherapy, local therapy with external beam radiation and enucleation, whereas systemic therapy with chemotherapy with 3 drugs, vincristine, carboplatin, and etoposide. Chemo reduction is the most important advance in the treatment of retinoblastoma, making more and more globe salvaging procedures possible. These drugs can be used in a special regimen to increase the survival of the eye. Special consideration during enucleation technique in retinoblastomas is slightly different from the conventional enucleation procedure. Minimal manipulation surgical technique is used. People who are doing or are skilled in doing enucleation in retinoblastomas are recommended to do such a procedure. Delicate hooking of the rectus muscles owing to the thin sclera underneath is a rule, and the longest stump of the optic nerve possible should be obtained, ideally nothing less than 15 millimeters. Use of biointegrated implants or non-biointegrated implants is a rule in case of the cosmetic correction of retinoblastoma, but biointegrated implants are not ideally advisable in cases where radiotherapy has been planned. The radiotherapy can lead to poor integration and extrusion of these coarse surfaced implants later on. Prosthesis fitting, however, over the implant can be done 3 to 4 weeks after the primary surgery. Treatment of primary orbital retinoblastoma, that is, at diagnosis it has an extraocular extension. 3 to 6 cycles of 3-drug high-dose chemotherapy followed by surgery, which is followed by 12 cycles of conventional chemotherapy, is the standard protocol for primary orbital retinoblastoma. Now we come to the next tumor, that is the choroidal melanoma. It is the most common primary intraocular tumor in adults, the most common tumor being metastasis. This accounts for 80% of the primary cases of primary tumors in the eye. It's explained by the extremely vascular nature of the uvea that secondaries are the most common intraocular tumors in adulthood. Symptoms depend on the location and the size of the tumor. Small lesions are asymptomatic. Large ones can cause a field defect or entoptic phenomenon like balls of light, which is very, very specific to this tumor. Age of presentation is usually in the late 6th decade. Signs are oval subretinal mass, which is a classical presentation, associated exudative retinal detachment, as in case of exophytic retinoblastomas. Classical feature is, however, the presence of lipofuscin pigment over the surface of the lesion. Breakthrough of the Brooks membrane into the eye can give some sort of a mushroom-shaped appearance because of the breakthrough, and if sufficiently large can give rise to choroidal folds, hemorrhage, secondary glaucoma and cataract if it comes and touches the posterior part of the lens. Histological features of this particular tumor are done according to the modified calendar classification, in which it is classified into spindle cell, pure epithelioid, mixed cell melanomas and necrotic melanomas. Epithelioid cells in melanomas are associated with worst prognosis, and spindle cell and mixed cell melanomas are almost equal in incidence. Investigations again are common for all intraocular tumors like we did for retinoblastoma. Diligent examination with indirect ophthalmoscopy and scleral indentation is mandatory. B-scan USG is an accurate method of diagnosis or determination of size, acoustic hollowness. Choroidal excavation and orbital shadowing are characteristic of this lesion. ICG angiography is a technique similar to fluorescein angiography done with a different dye which has less permeability to choroidal vessels because they have larger pore size. They delineate the choroidal vessels better than the fluorescein angiography and can also delineate the vasculature of the tumor. CT scans for extraocular extension has no advantage for the diagnosis or in case of tumors that are confined to the ocular codes. To rule out metastasis, it is very, very important that we do an examination of the liver, which is the most common site of metastasis, a USG abdomen, a liver function test, and an X-ray test for metastasis of the ocular lesion. Similarly, to rule out the tumor as a secondary from an extraocular site, X-ray chest mammography, rectal examination are supposed to be done because the bowel and the bronchus are the commonest site which are metastasized to the eye and the choroid. Treatments are based on the recommendations of the collaborative ocular melanoma study, which is a specialty topic in itself. Treatment, again, like retinoblastoma, is individualized on size, location, activity, state of the fellow eye, and health and age of the patient. By and large, less than 20 by 10 millimeters are treated by a special technique called as brachytherapy by radioactive iodine 125 plaques which are placed on the sclera. By and large, small posterior melanomas do well with charged particle therapy, transpupillary thermotherapy, and photocoagulation. Less than 16 millimeters with good vision can undergo a transscleral resection. Big tumors with no visual prospects confined to the globe can undergo enucleation. Metastasis to the orbit need an orbital exentration, that is removal of the globe, the contents of the orbit and the periorbita. And metastasis elsewhere can be only treated with palliative therapy. Coming to the third most important tumor, so-called the most aggressive tumor of all, or the primary orbital tumor in children, that is the rhabdomyosarcoma. As the name suggests, it is a mesenchymal tumor. Arises from undifferentiated pluripotent mesenchymal cells, histologically classified into embryonal, which is the most common, alveolar, having the worst prognosis, and pleomorphic. Age group is the first decade, 70% before the age of 16 years, and notorious for rapid progression over days. This is very, very important. In days to weeks, this tumor can spread. The dangerous part about it is it mimics orbital cellulitis, which is an infectious condition which can be treated easily, whereas this is a disastrous condition which can lead to local and systemic spread. Location is mostly in the retropalpar space or the cone. Proptosis is one of the first signs because the eyeball is pushed out by the fast growing tumor behind the eyeball. Swelling and injection of the skin, however, the skin will have a hyperemia but will not have a raised temperature as in orbital cellulitis, and symptoms of erosion into the sinuses due to local spread into the paranasal sinus. Metastases are common to the lung and the bone. Treatment is radiotherapy followed by chemotherapy. So in this stage, surgery does not find a primary role in the treatment of this disorder due to the exquisite response to radiotherapy as well as extensive occurrence inamiable to surgery. Vincristine, actinomycin, and cyclophosphamide are the preferred agents, and exentration is reserved only for recurrence or treatment of resistant tumor resistant to radio and chemotherapy. 90% survival rate is seen in these patients if it is confined to the orbit alone. So in this presentation, we have seen basically the three most important tumors of the eye as well as the orbit, and the important points among them which indicate the ideal way of treatment and the prognosis. All these ophthalmology modules that we have tried to make, we have tried to incorporate the basic concepts in such a way that the understanding of the topic is improved, leading to a faster grasping of the subject, lesser effort required to read the subject time and again, and easy implementation in your multiple choice questions in the exams.